Well, thanks for the opportunity to speak to you all. My name is Chia Wu. I'm from Houston, Texas, here at Houston Methodist. The previous speakers have covered really well. In fact, the first speaker did mention external fixation, and I'd agree with the question in the comment section that usually I recommend 0.45 or 0.45 as well. The point made about the 9-inch long K-wire is actually pretty critical because if the traditional ones that typically come in the set usually is about 7-inch long, and other times you can, depending on what kind of construct you're trying to create with the K-wire, the 7-inch long, sometimes you run out of length. So that's actually not a trivial point. And ideally, at least for me, another tip is that the double-ended ones that's sharp on both ends usually helps me as well. So to get into this case, this is a case of mine, 60-year-old HVAC technician, fell on his left middle finger on exam, PIP very swollen, with 10 to 30 degrees of active range of motion. So this is a manual worker with a pretty bad fracture pattern. So this is almost like a combination fracture pattern. So when you look at it on the lateral, you can see there's dorsal displacement and there's a large volar piece with a high exiting fracture line, metaphyseal very distally. So it's behaving like a dorsal fracture dislocation of the PIP. But at the same time, there's fracture lines multiple in multiple planes extending dorsally. So in that regard, it's also behaving like a pilon. With this amount of comminution, there is consideration, whether it's going to hold plates and screws to use K-wires. And traditionally, this is being a difficult fracture to address with very difficult outcomes. So to go over the options that some of the previous speakers have addressed, you have different choice of fixation, different constructs, plates and screws, intramedullary nails. The goal really just comes down to in what combination can you achieve anatomic fixation that allows for early range of motion that is stable, as biologically as friendly as possible. Specifically also to the PIP, what will allow you to restore a congruent joint with a smooth arc range of motion. Because even if the joint surface is not, perfectly reduced, if there is a smooth arc of motion and restoration of joint, like a congruent PIP joint, oftentimes the joint can remodel over time as well. X-Fix comes in two flavors, static and dynamic. And static flavors of this, which I'll go into some in a little bit, usually speaking, I would recommend for soft tissue contractures. Oftentimes they're quite useful. If there's severe soft tissue contaminations, you think about coming back with multiple visits, multiple washouts could be useful. But in the fracture setting, oftentimes we like to use the dynamic external fixator because it allows for range of motion early on, especially if you're able to do it in a way that that gives you a little bit of distraction and you can actually correct for deformity. Mainly just for these highly comminuted lengths unstable fractures, referring specifically to pilon, dorsal fracture dislocation is the most common indication. With a K-wire, you can actually allow for maintenance of length, alignment, rotation, early range of motion. Unlike some, we mentioned cost, Dr. Mihir's slide, that these are usually pretty cost effective, especially if you're in an austere environment. The static flavors of this on the left that you can see, you can actually make it pretty cheaply with just a syringe and PMMA cement and just K-wires. There's also pre-made ones by the company that allows you to dial in some degree of distraction in the lower left-hand corner. And the dynamic X-Fix on the right-hand side, as you can see, it comes in a couple different configurations. There's been a lot of different configurations published in the study, but they all really come down to a couple basic principles. So the first one is popularized by Dr. Suzuki, Dr. Slay, and external fixators. The principles are the same in that there's fundamentally comes down to two separate wires, typically one wire in the head of the proximal phalanx and one wire in the head of the middle phalanx. And these two provide 2 points of fixation. And then there has to be a power source typically. In this case, you can use a rubber band, and there's also an all-metal construct that the first speaker introduced that you can use. So it's important to insert these on perfect laterals, because if the two K-wires that you insert are not perfectly aligned, that can actually introduce deforming forces and actually make things worse. So these are actually technically quite demanding procedures. Another pitfall commonly seen is that if when you bend the wire, they're not of equal length, you can actually introduce unequal tension and cause malalignment as well. So um, as you can see, and then another modification is that you can actually introduce a third wire. And the reason for introducing the third wire is that you can actually use it to introduce volarly directed force, or in some cases dorsally directed force if you're looking at a volar fracture dislocation. And this is frequently useful just because you can bring that the dorsal cortex more in line to create that congruent joint. There's an all metal construct. In this case, you're using the natural bounciness in the middle of the K-wire to serve as your power source to provide a distraction. So very similar to the other one, except you're trying to generate the power through the natural bounciness, the springiness inside the K-wire. And typically these are 0.045. So coming back to our original case, I elected to fix this with a all metal construct. As you can see right here, a little bit of distraction. In this case, to be critical, I probably would have liked to get a little more length. For these, in terms of post-op protocols, I typically recommend a soft dressing and immediate gentle active and passive range of motion with access to therapists as soon as possible, with a planned KY removal usually 4 to 6 weeks post-op. But certainly, like any other techniques, there are complications. So specifically in my case, you can see that the all metal construct, research-wise, has been shown that they can uncouple and that can introduce a deforming force. As you can see, you're requiring the bending of the metal to provide, making sure that the two wires are engaged. Other complications that's been published, including pin track infection, which can introduce osteomyelitis, which is also suboptimal. Uncoupling we saw in the previous slide. Over distraction is also common, and that certainly can contribute to extensor lag by changing the balance of force between the extensors and the flexors, especially typically used with a metal rubber band construct. It's hard to sometimes control depending on the length and the choice of rubber bands to make sure that you're distracting just the right amount. Of course, post-traumatic arthritis, there could be persistent malalignment, and especially could be quite bulky, especially if you're using this technique for non-border digits like middle and ring finger. Sometimes the ends of the wire can poke into the bordering digits, and that could be quite bothersome for patients. As far as the outcome is concerned, the most recent paper based on a literature review actually comes from the journal Hand in 2021 that was published, where they did a systematic review when they looked at over 2,000 articles, ultimately 48 met eligibility criteria, and they grouped them into 5 categories. Open reduction, percutaneous fixation, dynamic X-fix, extension block pinning, and hemi-hemi and these include both, dorsal fracture dislocation as well as pilon type injuries. Essentially, what they found is that the choice of technique in these systematic review didn't seem to matter too much. They did find some trends, though, that the perc pinning seemed to have the best range of motion. Extension block pinning seemed to have the best grip strength, but the author concluded that no one method is definitively superior. So I think it's fair to say in 2025, it's the choice of fixation is still depending on the surgeon and the specific fracture pattern that's at hand. In summary, I would say consider external fixation in the context of phalanx fractures, specifically for fracture dislocation of the PIP. I would consider for pilon types. These are I think the best indications in the setting of phalanx fractures. Consider the choice of metal versus metal rubber band construct. With the metal one, you have to be concerned about uncoupling as a potential complication, and over distraction sometimes can be common with the rubber band construct. And just remember that whatever method you choose, just make sure that it's the most stable, most biologically friendly, and most anatomic fixation you can achieve regardless of methods. So sometimes you even have to mix techniques to achieve that. This is one of the other techniques using the K-wire that I've had pretty good luck in. In this case, it's a dorsal fracture dislocation, and you can see you can use a perk technique to try to reduce the fracture using a clamp, and then 2 small K-wires to reduce the fracture, and then 1 dorsal block pinning. So I've had pretty good luck with this technique too. That's pretty much it for my talk.